What's up, everybody? Happy Friday. Checking in. Everybody's had a good week. Waving back at you. Welcome to the regulars that are in here. For anybody that's new that's in here, welcome in. It's our Friday performance Q&A. You get to ask me anything you want regarding health, fitness, coaching, training, whatever you need. So, for my YouTubers, you got your chat feature. For my Instagrammers, you guys got your comment section. Ask whatever you want. Um, I am open to pretty much anything here. So whatever you guys need, let's see what's going on. Um, I got a couple emails over the week about having clients or patients of theirs that, or clients mainly, um, who might not be able to do a specific movement or can't do a specific movement. You don't have to force stuff, right? That's big takeaway. Like just because there may be a squat, for example, if your client or patient can't do that squat, for whatever reason, they don't feel comfortable, they don't like it, whatever, then don't force that, right? Even with the overhead squat assessment, I know sometimes, especially dealing with practitioners or if you're working in a clinic, that overhead squat sometimes might be a little too much for somebody, or they don't have that full capacity to do that movement. So we can modify things accordingly. We don't have to do the overhead squat. We can do like a sit to stand transfer or something along those lines. And you're going to get kind of the same feedback or the same information there with that. So don't feel like it has to be a squat. Don't feel like it has to be, like I said, that overhead squat. We can modify that, regressing. I know last week we talked about progressing that, but regressing that overhead squat and making it more of kind of a sit to stand side of things more than anything else. Teach dance, help with tight subscap. Subscap is one of those muscles that tends to be overactive, especially when we have upper body dysfunction. So, assuming you do that overhead squat, your arms fall forward. Subscap's kind of a player in that game. And there are a couple ways to get to that. There are a couple release. One of the releases is actually with that like stick or that hook. I don't know if you guys have seen that before. Um, so that's one way. Obviously, manual therapy can work as well, but um, from a corrective exercise standpoint, right? You go, okay, let's kind of address what we can. You have lats that are probably going to be overactive as well. You have your teres major, and potentially pecs that are in a shortened position. So do that same kind of treatment plan of release the lats, release your teres major, maybe get that release that subscap if you can, and if you can't get it, then do the best you can, and then make sure you're incorporating that other side of the equation of your activations and integrations, right? And if it's significantly painful, or if it's not getting better, and you're doing the best that you can do on your own, then and it's not getting better, then maybe it's time to go see somebody, go consult with a physiotherapy friend or a chiropractor friend or something like that, or get a second opinion there, because there might be something else, right? It might feel like um, a subscap thing, or it might feel like a hip thing, or it might feel like a back thing, but it might be something a little bit more than that. That was just kind of a quick example there. So hopefully that's helpful. Like I said, I would do your assessment. You're probably going to find arms fall, release the overactive stuff, and then activate that underactive muscle of more than likely posterior rotator cuff, mid low traps. You also have your serratus anterior that would be in there as well. Right. Um, I don't know anything about the cold. I'm sorry. Sorry about that. Causing pain. I don't know. It's probably just not fun to be sick. So, um, or be cold. That's why I live in Texas. Is there a relationship between muscle flexibility and hypertrophy? None that would be kind of a none that I know of that would be kind of a glaring relationship. I do know sometimes when you have uh, people that build muscle and don't really focus on any mobility or flexibility issues, that increase in size of muscle causes reduction in the potential range or their range of motion. But that's not always the case. I've worked with a few hypertrophy based clients, bodybuilders, physique competitors, things like that, who were incredibly flexible. So I don't think there is a definitive relationship there between hypertrophy and flexibility. Now, I will say the relationship that does exist is between, let's say, flexibility and strength, right? And I don't mean like just being strong, more so like the relationship between being flexible or overly flexible or hypermobile, and the trade-off that has with stability and control, that kind of stability strength of the muscles and tissues in the joint. So there is a way to be obviously hypermobile, which can cause a reduction in joint stability and control, muscular control, just like there could be this relationship between being super super big, right, huge muscles, hypertrophy side of things, and lacking flexibility or lacking range, optimal range of motion because the size of the muscle is just too large, right? When you think about your competitive bodybuilders like the Jay Cutlers and Ronnie Colemans in the world, they certainly have some range of motion restrictions simply because their mass is so large, and that's kind of the inherent name of the game that they're in. So, like I said, I think for kind of the average person or the average population, there isn't necessarily a definitive relationship between the two. But when you look at those extremes, or when you look at the ends, the hypermobile has a reduction in joint space, or sorry, a reduction in joint stability and control, and your super hypertrophy based clients or patients or whatever may have some restrictions in flexibility. Hopefully that's helpful. Right? Seated rows, straight back or slightly lean back. So I don't want to lean. I want to stay fairly upright, just like I would be if I were standing doing that. You can maybe get a little slight lean back, but I tend to stay nice and kind of straight and aligned, right? So um, hopefully you're not leaned back too far or leaned forward too far in those rows with the seated rows. Right? But I tend not to do, and I know obviously it's different for everybody. But I tend to not do a whole lot of seated rows. I do a lot more standing rows. I think that's a little bit more incorporate that core a little bit more. But that's one of those exercises that I've kind of gotten away from with the seated row side of things. But you can do whatever you want, strong like mom. You could. Yeah. What else you guys got? My YouTubers, where you at? Ask me stuff. Um, for a pinched nerve, do I have suggestions? Yes, I do. Go see somebody. I don't know if you knew that was coming or not. Obviously, when you have some sort of pinched nerve irritation, something that's causing somewhat debilitating pain, go get it checked out. Go see a chiro, see a physical therapist, see somebody that can actually kind of do some assessment on you, and potentially do some therapy for you. Obviously, if it's significantly uncomfortable, then go orthopedic and go to the doctor and see what you need an MRI or something like that. So, not the answer I'm sure you wanted me to say. I wish there was just yeah, just go do this and you'll be cured kind of thing. But unfortunately, there's a lot of things that can contribute to that. So I don't know. Hopefully that's not you. Hopefully you're asking for a friend and you're not in any pain or discomfort because you're super strong and awesome. When taping for corrective exercise, how should we address lengthening and shortened muscles? When you mean taping, are you talking about KT tape or kinesio taping? Because if you are, really what we're doing is the taping side of things. Um, you tape those kind of underactive or those commonly underactive muscles, and there are actually some videos on the website for this. So if you think about, I'm going to use upper body so you can see me, right? So most people have that kind of like internally rotated, anteriorly tipped scapula, that kind of that captain protraction position. So what you want to do is you want to position them in optimal and put that tape down, right? So you're not kind of going on a full stretch. You're not going really anywhere other than just kind of putting that tape on that, let's say, infraspinatus, teres minor, those external rotators. You're going to put that tape on those muscles. And now, anytime they come out of that optimal, so they get that shoulder kind of pulled, when they get that shoulder to kind of roll forward again, they get a little bit of tug on that tape. And that should give them a little bit of a tactile cue to get them going, like, oh, I got to get back here, right? So it just gets a little bit stiff there from that tape pulling, and it allows them to, pull them back, or hopefully they can kind of actively pull themselves back. So hopefully that somewhat makes sense. I'm not necessarily taping shortened muscles because I don't want that to, get taped. I don't want that tape pulling me further into that compensation. So, I use a silly analogy of, we use taping as more like your, grandparent who used to yell at you or smack you when, you started kind of slumping in your chair. That's kind of the taping side of things. That's how we use that for, right? So, when you get out of optimal or get out of ideal, that tape kind of gives you a nice little tactile cue to get back to how you're supposed to be, right? And it doesn't work perfectly, not always, right? There's always these cases of, not being, it's not the end all be all treatment, but it is an additional support mechanism that you can use to help kind of with some carryover into what you're doing with that person, addressing those shortened and lengthened muscles, or overactive and underactive muscles in your treatment session. So again, hopefully that makes sense. There's some good videos on the taping, so go check them out if you have more questions. But like I said, position them in ideal, lay the tape down, and then kind of like set it and forget it kind of thing. Mm. Dating myself with those infomercials, right? Herniated disc felt like a cold at first. Yeah, that's not fun, right? So, the feelings side of things, we say this in our workshops and we talk about this a lot. Don't use your feelings as your diagnosis. We have a terrible perception of, what the root problem is. So feelings are not facts. Just kind of keep that in the back of your head. You need a reliable assessment to really determine or diagnose what's going on, not just kind of how you feel. So, if you have a herniated disc, I feel terrible for you. It's not fun, but hopefully you got that checked out, fixed. Let's see how to rehabilitate weak muscles, gastroc, hamstring, glute after nerve damage at S1. PT, 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 PT. I can't emphasize that enough. Obviously, the PT that you're going to hopefully has you do some home exercise stuff. Um, obviously, a nerve damage issue is completely different than just kind of the traditional. Oh, you have overactive, hip flexors, or overactive this, that, the other thing. Nerve damage is a completely different realm of things. So there's not much I can give you without diving deeper into assessment and kind of being there. So I would suggest go to PT, do what they say, and if you don't like that PT or you're not seeing results, then maybe you need to shop around a little bit, um, because there are good PTs and then there are not good PTs, and you just got to find the ones that actually have provide you those great outcomes that you're looking for. But like I said, that nerve damage stuff, you're certainly going to need some help, more than I can give you on Instagram for sure. Right, but keep working. You're going to be fine. Promise. Right. Um, keep on rocking and rolling. Any advice for jam joint in the big toe? You got, call it turf toe. You've been running on the field. Um, Again, kind of nothing specific that I can give you via Instagram. Just kind of keep moving. There's certainly some mobilizations if you got some, or manipulations, that if you got a chiro friend or a PT friend or somebody who's able and within their scope of practice to do manips, maybe they can take a look at it. Um, but sometimes it's just movement and recovery and not doing whatever it is you were doing that jammed your big toe. So, and I know it seems like every time you get hurt with something, like a toe or finger or whatever, you bump it into everything and everything in your way, right? So you manage to keep on, making it angry. So no Sorry, Michelle, no super crazy awesome advice for you there. All right. Let's see. You had a patient who had an ACL injury and take a ligamentoplastic. Uh, awesome. Hopefully they're all right. Keep working on them. Yeah. Let's see. What else you guys got? Good questions. Thanks. Um, I'm in California. Is there any way for me to become a patient or client? I do virtual stuff, but I'm starting to kind of get away from that. But send me an email. I can. It's easy. It's Dave at brookbushinstitute.com if you have more questions. I have a couple clients. One of my clients is the worst. She's actually on right now asking questions. She's just nothing but trouble. How do you deal with a PT that has trouble returning a joint to its normal resting position after contraction? Um, deal with a PT. Trouble returning a joint to its normal resting position after contraction. Go see somebody. No. Um, uh, let's see. So that's a good question. I'd have to kind of get a little bit more on what you're dealing with, what you're kind of looking at, what you've tried, right? And kind of go from there. So again, if you're um, if you have too much neural drive into that particular muscle, that can pull that joint kind of when you have some arthrokinematic issues there. So I have to get a little bit more on what's going on, what you've tried and what you're doing. Um, so sorry, I can't help you too much there. I know you ask good questions all the time, so I'm sorry I got a blank for you on that one. Let's see. There you go. There's the rest of that question with the ACL. Obviously, there's going to be some imbalance walking. There's going to be some quad and hamstring stuff. Obviously, glute stuff. Glute's going to shut down, right? Um, so, so with that kind of side of things, that recovery and treatment side of things, again, you've done your assessment, you know what's going to happen, you know that the glutes for the most part are going to be that big muscle that's going to take forever to get back working or get back on, right? So I think when it comes to a lot of those repairs and replacements and things like that, especially in lower extremity, glutes are like the one that lags behind everything else. So what I would suggest, obviously, do your quad stuff, do your TKEs, do whatever hamstring activations you want to do. I would limit that though. I'd more so really try and focus on getting that vastus medialis to fire because that's going to be delayed too. I think you're going to get the rec fem, vastus lateralis, and even bicep fem to kind of ramp up its activity a little bit first, or kind of they're going to be the ones that kick back on first, even though sometimes they're not responsible for the movements that you're or solely responsible for the movements that you're looking to get. So I would probably focus on a lot of the glute work. So you have your clamshells, you have your straight leg lifts, you have your prone hip lifts or prone leg lifts, depending on what they can do and their capacity at which they can do it. So I would probably focus more on the glute side versus the specific kind of hamstring side specifically, because a lot of those exercises that the glutes are kind of contributing in, hamstrings are going to work with them, and that's kind of what we want. We want hamstrings to work with glutes, not hamstrings to work and glutes not. So I would focus on some glute work. Obviously, you got to get that in range knee extension back, right? So those TKEs are great. The knee mobilizations you can try as well. Obviously, if you're a manual therapist or a physiotherapist, then you can do some of that. Try and get some of that in range because that's going to be a little bit. That might take a little bit to get back to, and just kind of keep going. Keep pressing the glute work. Keep pressing that VMO work, and I think everything's going to kind of come back with that. I would also suggest up to 2 years post operation. So I would definitely go into some more higher level side of things as well. So again, depending on what that person can do, that kind of classifies their higher level. But do your corrective exercise warm up, right, or intervention, release the overactive muscles, do that squat assessment, see what you find, right? More than likely you're going to find knees bow in or excessive forward lean or asymmetrical weight shift, since you're saying there's an imbalance when you see them walking. So once you find what you, or once you get what you see in that overhead squat assessment, go back to the math, do the math, right? We have all the answers or solution tables for you on the website, but see what muscles will be overactive and then focus on those. Do the releases, do the joint mobilizations, do the lengthening techniques, and then go into your activations and integrations, right? And that would be kind of like their warm up or their treatment session with you. You can do it 1 or 2 times through, and then give them some homework of some things that they can do on their own, right? Whether that's hip bridges or maybe some lunging or step ups, or again, just kind of making that fit what their capacity is. But I would definitely say do that overhead squat assessment, whatever capacity they can do it in. Maybe they can't do the overhead squat, maybe they do the sit to stand transfer, right? Gather what you see, and then come up with that solution table of what muscles need to be released and mobilized and lengthened, and what tissues need to be activated and integrated. So that would be my suggestion there. Um, Again, hopefully that's somewhat helpful. I think what you really need to focus on, especially somebody coming off of um, surgeries and things like that, even 2 years ago, we have to get a little bit more systemized, right? A little bit more of a systematic approach with treatment that we can really measure outcomes, right? So I think if you go that way, it's a little bit better than just kind of throwing stuff at the wall and seeing what sticks, right? So, oh, a little bit of this, a little bit of that, a little bit of this, a little bit of that. I think that's kind of the wrong method, or the wrong way to go about things. But think more of that based on my assessment, what tissues need to be released, mobilized, lengthened, and what tissues need to be activated, integrated, and try that. And if it doesn't work, then come back on here and yell at me, right? I'm all right with that. Mbaluka, I'm sorry if I've said your name wrong. You're welcome. Thank you. What are my pull-up prerequisites? Um, Coach Carly. So my pull-up prereqs, I don't really necessarily have like you have to be able to do X, Y, and Z before I have you do a pull-up. Obviously, they should be able to hang or hold their body weight up from a bar, but I treat pull-ups kind of the same way I treat everything. Is there's lots of progressions and regressions to that pull-up. So maybe I use bands for somebody, or maybe I use the assisted pull-up machine, or maybe I use jumping pull-ups with an eccentric control down. I really don't have a specific prerequisite, because pull-ups at the end of the day are just a hard exercise, right? They're hard for two reasons. Number one, they're hard because you have to convince yourself that you have to do pull-ups. And number two, they're just a hard movement, right? It positions your muscles it positions your lats specifically in a very kind of like tough position to produce high force at that end range motion at the beginning of a pull-up, right? When you think of that pull-up and you're hanging from the bar, lats are lengthened, right? And a lengthened muscle based on that length tension curve is not a very strong muscle. So that first initial pull becomes really, really difficult, right? So I just try stuff, right? I go, okay, we've done rows, we've done this, we've done this, we've done this. Let's try, doing a assisted pull up with the band and see how you go, and just kind of get the feel for it. And that's where we go from there. So, Coach Carly, I'm sorry if I didn't answer your question either specifically or exactly how you wanted it to. There is no perfect system. Everybody's a little bit different. I've had clients never stepped foot in the gym before in their life. They jump up onto a pull-up bar and knock out 15 pull-ups like it's nothing. And I'm just like, what's happening here? Is this real life? And then I've had other people who've been training their whole lives, and pull-ups are still hard. So I think it's just kind of I don't know, kind of it depends on the person kind of thing. So beautiful. Good questions. Great questions. Keep them coming. I got a couple more minutes. Um, Core, Adonis, what's up? Core work, only endurance and stability, or also strength where there's low reps, duration, and high intensity? You can certainly do whatever you want. There's some core exercises that we kind of use for the endurance stability side. And then there's some higher level core exercises that include, let's say, like mountain climbers or crunch and catch where you're throwing a ball to somebody. So there's other options, not just planks or side planks or bridges or stuff like that. There's certainly other options, but what I would recommend for most people, especially just starting, is that endurance stability side of things first, right? We want to make sure we can control that, and then we can progress to those higher level things, right? So I have no problem with adding crunch and catch throws or med ball slams, actually, kind of a core thing. Also, those mountain climb, all that stuff can be used in there. Same with like, you can do a crunch, right? It's not the workout police aren't going to come get you. You can do dynamic wood chops off with a cable machine or something like that. Again, we want to make sure those are not kind of the first thing somebody does when they walk into the gym day one, right? We want to make sure they have control of those joints and control of that movement first. And then we can kind of sprinkle some of that stuff in later on, right? The next couple phases that next couple phases of our periodized program. Um, but kind of that's where you go. Now, obviously, if you've been working out for your whole life, yeah, sure, do a couple crunches or do a couple dynamic wood chops or whatever. If that's what you like and that's what you want to do, go for it. Right? Cool. Let's see. Driven to be fit for life, any key exercise to improve knee strength and stability and overcoming patellofemoral syndrome? Two things I would say. Number one, check out the knee mobilization. As long as you're not hypermobile in the knee, check out the knee mobilization on the website. The self-administered knee mobilization, so it's with a band. That one's pretty good. I've had some success with people who have had patellofemoral pain. So check that one out. And then the other one would be the TKE. I think the TKE and all glute stuff is helpful for that. So I would check that out. I know it kind of seems counterintuitive that glute stuff would help with patellofemoral, but it does. Trust me. All right. I cannot explain about the sports physiotherapist psychology during the on-field injury assessment within given time of 2 minutes. No, usually an athlete that gets injured has sheer panic, and then the physiotherapist runs out on the field and saves the day. But other than that, I don't know any of that. I'm sorry. I haven't looked at that stuff in a long, 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 long time. So I apologize. Guys, happy Friday. Hope you had a good week. Hopefully you have a great weekend. Um, I am telling you now, I'll probably, tell you, you guys will probably see it again. I will not be on next weekend, but I will be on the week, or I won't be on next Friday, but I will be on the Friday um, after Thanksgiving, and we're all happy and stuffed full of turkey. So, for those of you guys, I won't see you next weekend. I'll see you in 2 weeks. Go have a great couple weeks, and I'll see you next time. And go be awesome. Go do great things. Thanks again for your awesome questions. See you soon.